Yeah, thank you very much, dear colleagues. An honor for me to be here, to be allowed to present the data of the MonDAFIS trial today. First of all, my disclosures are depicted here. There's another disclosure, so I'm a neurologist, not a cardiologist, probably the only one in the room. That's why I want to state it in the front. So the background, I think, is pretty clear. We've heard atrial fibrillation is related to the risk of stroke, and oral anticoagulation is recommended. And of course, prolonged ECG monitoring increases the rate of AF detection in stroke patients. And as the EHRA concept failed in recent randomized controlled trials, AF detection is important for secondary stroke prevention, as you all know. There are a large number of cohorts. Every dot in this slide is representing one of these cohorts, focusing on stroke patients without detected AF. And I think it's pretty easy to see that the longer you monitor, the more AF you will find. Of course, there is a kind of selection regarding to baseline characteristics, and there is no surprise that elderly patients after stroke have a higher risk for AF detection, and it's also no surprise that those patients with atrial cardiomyopathy have a higher risk of AF detection after stroke. And as you all can see, there's a focus on the acute phase or the subacute phase, and there's also a focus on those patients with cryptogenic stroke or the EHRA patients. But there is a problem. There are few randomized controlled trials like CRYSTAL-AF, like EMBRACE or FIND-AF randomized, but those trials have been too small to demonstrate a benefit regarding the reduction of clinical endpoint like recurrent stroke or even death. And even two recently published studies, PERDEEM and STROKE-AF, together including about 700 or 800 patients after stroke, could not demonstrate such a benefit. They nicely demonstrate that in the control group, there was not much going on. So AF screening is not standardized in non-hospitalized stroke patients. But from my point of view, the STROKE-AF trial is of interest, just demonstrating that if you include patients within 10 days after ischemic stroke and you randomize these patients to an implanted loop recorder or usual care, you will detect more AF in patients with large vessel disease or those patients with even small vessel disease. Both cohorts so far underrepresented regarding screening studies. So a few years ago, we decided to do a trial. We started this investigator-initiated trial in Berlin, and we decided to focus on hospitalized patients because screening is much easier in such patients compared to patients in the ambulatory settings. And we also focused on all comers in the acute phase of stroke. And the so-called MonDAFIS trial was supported by a grant from Bayer Vital and was also supported by the AFNET. And the aim was to demonstrate that a systematic ECG monitoring in hospital improves detection of so far undetected AF in such patients, increases anticoagulation rates, and in addition also reduces cardiovascular endpoints in those stroke survivors. It was an open trial, and we recruited patients in pretty close to 40 certified stroke centers in Germany. And the intervention was that we added Holter ECG monitoring for up to 7 days in hospital, which was analyzed in a cardiac core lab on top of usual care, and we compared it to usual care in those patients hospitalized in a stroke unit. So we included patients aged 18 years and older, and patients had to have an ischemic stroke or a TIA with symptoms on admission, and we excluded patients with known AF, and we excluded patients with a given indication for anticoagulation besides atrial fibrillation. So the primary endpoint was the number of patients on oral anticoagulation after 12 months, and key secondary endpoints was first the number of patients with detected AF in hospital, and the second, the proportional number of patients with recurrent stroke, myocardial infarction, major bleed, or death within 24 months. And once again, this is a large trial. Just want to thank all the supporters listed here, especially just want to thank Matthias Endres, my former boss at the Department of Neurology at the Charité, and also want to thank Paulus. who was a member of the steering committee and also headed the cardiac core lab, and they had a lot of work to do in more than 1,700 patients. And even Renate did his part and validated some of the reports from the ECG core lab, but this was before Paulus went to Hamburg, I guess. So we recruited patients in less than 3 years, and mean duration of ECG recording was 5 days. Mean hospital stay was 7 days in total, and the patients had a median age of 66 years. About 40% of the patients were female. About 30% of these patients had a TIA as index stroke. About 20% had a prior stroke, and about 20% got thrombolysis, and stroke severity was rather moderate, as all the patients had to provide written informed consent. And here are the results. So in the control group, the patients underwent stroke unit monitoring in average for 3 days. And in average, they had 1 additional Holter ECG for 24 hours. And this resulted in new detected atrial fibrillation in 4% of the patient, so a rather high standard. And in the intervention group, we got a detection rate of 5.8%. This was statistically significant. And the main issue is that in the intervention group, no surprises here. So the elderly patient had a higher rate of AF detection in hospital, and there was a trend towards a higher rate of AF in stroke patients compared to TIA patients. Stroke severity did not impact on AF detection. So primary endpoint was the rate of oral anticoagulated patients, as said before, after 12 months. So we got 11.8% in the control group, and we got pretty close to 14% in the intervention group. This was not statistically significant. Interestingly, about 1/3 of all these patients did not have atrial fibrillation and were anticoagulated due to other reasons. So we recruited the patients in parallel to the aforementioned ESUS trials. So a few of these patients had ESUS and have been anticoagulated at this point in time, and there was a large number of patients with a PFO also anticoagulated at this time. Including those patients with atrial fibrillation being anticoagulated, there was a difference of 7 to pretty close to 9%. So once again, not statistically significant. So this small margin did not translate into a reduction of the combined vascular endpoint. Once again, recurrent stroke, myocardial infarction, major bleed on all-cause deaths, mainly driven by recurrent stroke and deaths. So in total, we got pretty close to 500 endpoint events in here. But interestingly, the mortality was reduced in the intervention group compared to the control group. And this was not driven by a higher rate of strokes in the control group. This was also not driven by a higher rate of pacemakers in the intervention group, but obviously a more informed guidance of antiarrhythmic drug treatment may play a role in this regard. We just presented the data on the ESC Congress a few months ago. So taken together, systematic ECG monitoring in stroke survivors increases AF detection rate, but systematic ECG monitoring in unselected hospitalized stroke patients does not result in a higher rate of anticoagulation at 12 months in the MonDAFIS trial. So systematic ECG monitoring in selected and non-hospitalized stroke survivors resulted in a higher rate of anticoagulation, but as said before, so far no randomized control trial, and not MonDAFIS, were able to demonstrate a significant reduction of recurrent stroke or death or MACE in stroke survivors. That's why further randomized controls are urgently needed just to justify systematic AF screening in selected stroke survivors, which is not standardized in many countries. And that's why I just want to draw your attention to the ongoing FIND-AF trial. This is a trial recruiting patients with ischemic stroke, which are older than 60 years of age and had the stroke within the last 30 days. There is a baseline Holter ECG monitoring and randomization 1-to-1 to the control group or the intervention group, and there is a stepwise approach in the intervention group. There is a high risk or anticipated high risk of atrial fibrillation detection based on the baseline ECG monitoring, then you get either 7-day Holter ECGs done 3 times within 1 year, or they get an implanted loop recorder. And this study is planned to enroll more than 5,000 patients, and that's why I think there is a chance to demonstrate a risk reduction regarding recurrent stroke with such a trial. Thank you very much.